Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 329 of our pharmacotherapy series, which majors in diabetes mellitus. The first question reads, JLM, a 40-year-old, 60-kilogram woman with an 8-year history of type 1 diabetes mellitus, is moderately well controlled on 24 units of insulin glargine plus pre-meal doses of insulin lispro. Her family brings her to the emergency department, where she complains of abdominal tenderness, nausea, and vomiting. According to her family, JLM was well until 2 days ago when she awoke with nausea, vomiting, diarrhea, and chills. Because she has been unable to eat, she has omitted her usual morning dose of insulin for the past 2 days. Her gastrointestinal symptoms progressed, and she was brought to the emergency department when she became lethargic. Physical examination reveals an ill-appearing woman who is lethargic but responsive. Her temperature is 37 degrees Celsius. Skin turgor is poor, mucous membranes are dry, and her eyeballs are shrunken and soft. JLM's lungs are clear, but respirations are deep and her breath has a fruity odor. Cardiac examination is within normal limits. In the supine position, JLM's pulse rate is 115 beats per minute and her BP is 105 systolic 60 diastolic. In the upright position, her pulse increased to 140 beats per minute, and her BP dropped to 85 systolic 40 diastolic. There is mild, diffuse tenderness over her abdomen. Laboratory results on admission disclosed the following. Blood glucose of 450 mg per deciliter. Sodium of 150 m equivalents per liter. Potassium of 5.4 m equivalents per liter. Chloride of 106 m equivalents per liter. Bicarbonate of 10 m equivalents per liter. Serum creatinine of 2.0 mg per deciliter. Hemoglobin of 15.7 grams per deciliter. Hematocrit of 49%. A white blood cell count of 15,000 per microliter with 3% bands. The normal range is 3% to 5%. 70% polymorphonuclear neutrophils. The normal range is 54% to 62%, and 27% lymphocytes. The normal range is 25% to 33%. Serum ketones, moderate at 1 to 10 dilution. Normally it should be negative. The urinalysis showed the following. Glucose 2+. The normal value should be 0. Moderate ketones. The normal value should be 0. pH is 5.5. The normal range should be 4.6 to 8. Specific gravity 1.029. The normal range should be 1.020 to 1.025. No white blood cells, red blood cells, bacteria, or casts are seen. Arterial blood gas results were as follows. pH is 7.05. The normal range is 7.36 to 7.44. CO2 is 20 mm of mercury. The normal range is 35 to 45 mm of mercury. PO2 is 120 mm of mercury. The normal range is 90 to 100 mm of mercury. What supports the diagnosis of diabetic ketoacidosis in JLM? The fact that JLM has type 1 diabetes mellitus puts her at risk for developing ketoacidosis. About 80% of diabetic ketoacidosis cases occur in patients older than 18 years of age, with about one-third of those occurring in patients older than 45 years of age. In diabetic ketoacidosis, an absolute or relative insulin deficiency promotes lipolysis and metabolism of free fatty acids to beta-hydroxybutyrate, acetoacetic acid, and acetone in the liver. Excess glucagon enhances gluconeogenesis and impairs peripheral ketone utilization. Physiologic stress contributes to the development of diabetic ketoacidosis by stimulating release of insulin counter-regulatory hormones including glucagon, catecholamines, glucocorticoids, and growth hormone. Common stress factors include infection, pregnancy, pancreatitis, trauma, hyperthyroidism, and acute myocardial infarction. JLM presented with symptoms of nausea, vomiting, diarrhea, and chills, and these are suggestive of an acute viral gastroenteritis. Patients such as JLM commonly discontinue their insulin in this setting, which can rapidly precipitate the development of diabetic ketoacidosis. As illustrated by JLM, patients with diabetic ketoacidosis present with moderate to high serum glucose concentrations secondary to decreased peripheral utilization and increased hepatic production. This increases serum osmolality, which initially shifts fluid from the intracellular to the extracellular space. When serum glucose concentrations exceed the renal threshold for reabsorption of about 200 mg per deciliter, glucose spills over into the urine and causes an osmotic diuresis that depletes the total body water and electrolytes. JLM also has lost fluid and electrolytes from vomiting and diarrhea. Eventually, as losses exceed input, the patient becomes dehydrated, dry mucous membranes, dry skin, soft, shrunken eyeballs, increased hematocrit, and intravascular volume becomes depleted, orthostatic BP and pulse changes. The finding of hyperkalemia in JLM is also common in diabetic ketoacidosis because insulin contributes to the intracellular shift of potassium. The relative deficiency of insulin in diabetic ketoacidosis results in an extracellular shift of potassium that is worsened by the acidosis that often develops. A finding of hyperkalemia in diabetic ketoacidosis, that is below 3.3 milliequivalents per liter, is uncommon and is a marker of more severe disease. In the hyperkalemic patient, the combination of the extracellular shift of potassium and polyuria has led to excessive depletion of total body potassium. Care must be used in these patients to replace potassium intravenously before beginning insulin therapy, which will cause further hyperkalemia as potassium shifts back into cells. Evidence of excessive ketone production in JLM includes ketonuria, ketonemia, and the characteristic fruity odor of acetone on the breath. Elevated levels of these organic acids increase the anion gap and decrease the pH and carbonate levels. The respiratory rate is increased to compensate for the metabolic acidosis leading to hypercapnia. The next question reads, how should JLM be treated? Treatment of patients with diabetic ketoacidosis is aimed at expansion of intravascular and extravascular volume, replacement of electrolyte losses, and cessation of ketone production. Regarding fluids, rapid correction of fluid loss is most crucial. The usual fluid deficit is difficult to estimate in the absence of overt hyponatremia but approximates 5% to 10% of body weight in most patients depending on the severity of the diabetic ketoacidosis. In the absence of cardiac compromise, hyponatremia, or significant renal dysfunction, isotonic saline 0.9% sodium chloride solution should be used. JLM has evidence of significant dehydration and intravascular volume depletion. Based on body weight, if the patient has the typical 5% to 10% weight loss, that would indicate approximately 3 to 6 liters of fluid will be needed to fully replete. 10% of 60 kg is equal to 6 kg loss and 1 liter is equal to 1 kg. It is recommended that fluids be replaced at the rate of 15 to 20 ml per kilogram per hour during the first hour, that is approximately 1 to 1.5 liters in the average adult. The subsequent choice for fluid replacement depends on the patient's state of hydration, serum electrolyte levels, and urinary output. If the corrected sodium is normal or elevated, 0.45% sodium chloride solution infused at a rate of 4 to 14 ml per kilogram per hour is appropriate. If the corrected serum sodium is low, 0.9% sodium chloride solution is preferred. When serum glucose concentrations approach 200 mg per deciliter, solutions should be changed to D5W in 0.45% sodium chloride solution. Glucose is added to allow the continuation of insulin therapy without causing hypoglycemia. We will now consider sodium. Total body sodium usually is depleted by 7 to 10 milliequivalents per kilogram of body weight in patients with diabetic ketoacidosis. In assessing serum sodium in these patients, it is important to remember that falsely low values, i.e., pseudohyponatremia, may be the result of hyperglycemia and hypertriglyceridemia. The corrected sodium value can be estimated by adding 1.6 milliequivalents per liter to the observed sodium value for every 100 mg per deciliter glucose in excess of 100 mg per deciliter. Sodium is replaced adequately with normal saline, which has a sodium concentration of 154 milliequivalents per liter. Next we will discuss potassium. Potassium balance is altered markedly in patients with diabetic ketoacidosis because of combined urinary and GI losses. Invariably, total body potassium is at least partly depleted, however, the serum potassium concentration may be high, normal, or low, depending on the degree of acidosis and volume contraction and severity of insulin deficiency. Usual potassium deficits in this situation average 3 to 5 milliequivalents per kilogram of body weight, although they may be as high as 10 milliequivalents per kilogram. Thus, JLM needs approximately 200 to 350 milliequivalents of potassium to replenish her body stores, assuming her normal weight is 70 kg. To prevent hyperkalemia, potassium replacement should be started after her serum potassium concentrations decrease to less than 5.3 milliequivalents per liter, assuming an adequate urine output of 50 ml per hour. The addition of 20 to 30 milliequivalents per liter is usually sufficient to maintain the serum potassium at greater than 4 milliequivalents per liter. In cases when serum potassium is low at presentation, that is below 3.3 milliequivalents per liter, potassium replacement should be initiated with fluid therapy, and insulin therapy delayed until the potassium level is greater than 3.3 milliequivalents per liter to avoid severe hyperkalemia and the risk of cardiac arrhythmias and diaphragmatic weakness. In these cases, initial IV solutions should contain 20 to 30 milliequivalents per liter of potassium chloride. Next we will discuss phosphate. Phosphate is lost as the result of increased tissue catabolism, impaired cellular uptake, and enhanced renal excretion. Like other electrolytes, serum levels initially may seem normal, even though body stores are depleted. However, replacement can result in hypercalcemia, and the use of phosphate in diabetic ketoacidosis has resulted in no clinical benefit to patients. Severe hypophosphatemia, that is below 1.0 mg per deciliter, can cause cardiac and skeletal muscle weakness as well as respiratory depression. To avoid this, phosphate can be carefully replaced in patients with cardiac dysfunction or respiratory depression when phosphate concentrations are less than 1.0 mg per deciliter. Potassium phosphate can be added to the replacement fluids in the amount of 20 to 30 milliequivalents per liter. The next question reads, what is an appropriate insulin dose and route of administration for JLM? Insulin therapy is the key to diabetic ketoacidosis management because it is what stops the production of ketones. As insulin allows glucose metabolism to resume, the counter-regulatory signals for ketone production are turned off. Unless the episode of diabetic ketoacidosis is mild, pH 7.25 to 7.30, and uncomplicated, regular insulin by continuous infusion is the treatment of choice. Once hyperkalemia, that is potassium below 3.3 milliequivalents per liter, is excluded or treated, an IV bolus of regular insulin at 0.1 units per kilogram followed by a continuous infusion at a dose of 0.1 units per kilogram per hour should be administered. This should decrease the plasma glucose by at least 10% in the first hour. If there is not at least a 10% reduction in the first hour, then a second bolus of 0.15 units per kilogram should be administered. Once the plasma glucose reaches 200 mg per deciliter, the insulin infusion can be decreased to 0.05 units per kilogram per hour. Alternatively, insulin can be switched to subcutaneous at a dose of 0.1 units per kilogram every 2 hours. Regardless of the route of insulin therapy, serum glucose should be maintained at less than 200 mg per deciliter. At this point, the fluid should be changed to D5W with 0.45% sodium chloride solution. Thereafter, the rate of insulin administration and the rate of infusion of D5W with 0.45% sodium chloride solution are adjusted to maintain the glucose value at around 200 mg per deciliter until the ketosis is resolved. Resolution of ketosis is marked by a serum bicarbonate level of at least 15 milliequivalents per liter, a venous pH greater than 7.3, and a calculated anion gap of 12 milliequivalents per liter or less. Once any two of those three findings are present, the patient can be converted to a longer-acting subcutaneous regimen. For mild diabetic ketoacidosis, that is a serum bicarbonate equal to or more than 15 milliequivalents per liter, anion gap less than 15, subcutaneous rapid-acting insulin has been used with no differences in patient outcomes. The advantage is that patients can be treated in a non-ICU setting, thus reducing hospital costs. The next question reads, JLM was treated with fluids, electrolytes, and insulin as discussed in previous questions. Laboratory and clinical data 4 hours after therapy are as follows. pH of 7.1. Blood glucose of 400 mg per deciliter. Potassium of 3.8 milliequivalents per liter. Serum creatinine of 3.1 mg per deciliter. Serum ketones, strongly positive at a 1 to 40 dilution. Her BP was 120 systolic 70 diastolic with no orthostatic changes. Urine output for the past 3 hours has been 500 milliliters. Because serum ketones have increased, should JLM receive more insulin? Should she receive bicarbonate therapy? The assumption that ketosis is worse in JLM is incorrect. In diabetic ketoacidosis, low levels of insulin and elevated glucagon levels promote the metabolism of free fatty acids in the liver to acetoacetate and beta-hydroxybutyrate. The standard nitroprusside reaction test for ketones measures only acetoacetate, even though beta-hydroxybutyrate is the more important ketone. The conversion of acetoacetic acid to beta-hydroxybutyrate is coupled closely with the reduced NADH to NAD ratio. If this ratio is high, as in the presence of alcohol, so much beta-hydroxybutyrate may be formed that acetoacetate is virtually undetectable. Thus, the absence of ketones in the serum does not rule out ketoacidosis. Conversely, treatment with insulin begins to suppress lipolysis and fatty acid oxidation. Nicotinamide adenine dinucleotide is regenerated, shifting the reaction back in favor of acetoacetate. Thus, even though there seem to be higher concentrations of ketones in the serum, JLM's declining blood glucose concentration, improved bicarbonate concentrations, and improved acid-base and cardiovascular responses indicate that she is responding appropriately. Therefore, no change in the insulin dose is indicated. It is important to emphasize that the glucose concentrations normalize before ketones 4 to 6 hours versus 6 to 12 hours because the latter are metabolized more slowly. For this reason, it is important to continue insulin to maintain suppression of lipolysis until plasma and urine ketones have cleared. The use of bicarbonate in patients with diabetic ketoacidosis has been controversial. Most investigators discourage its routine use, reserving it for patients with severe acidemia and hyperosmolality, calculated osmolality above 340 milliosmoles per kilogram. In a small randomized, prospective study, bicarbonate did not affect recovery in patients with severe diabetic ketoacidosis with an arterial pH of 6.9 to 7.14. Thus, even though JLM's acidosis seemed severe on admission, with a pH of 7.05, bicarbonate, 10 milliequivalents per liter, USMLE respirations, that is deep, frequent respirations resulting in blowing off of carbon dioxide, bicarbonate was not administered. It is apparent that with fluid and insulin therapy alone, her acidosis is beginning to improve. The next question reads, what is the expected course of diabetic ketoacidosis in JLM? After 3 liters of fluid and a constant insulin infusion of 6 units per hour for 3 hours, JLM's glucose concentration had dropped to 400 mg per deciliter and she had no orthostatic BP changes, reflecting recovery from her volume-depleted status. Potassium, 40 milliequivalents per liter, was added to her fluids, which were administered at a reduced rate of 300 ml per hour. 3 hours later, the glucose concentration had dropped to 350 mg per deciliter and her pH had increased to 7.21 with an anion gap of 24 milliequivalents per liter. The serum potassium remained low normal at 3.4 milliequivalents per liter, and serum sodium increased to 151 milliequivalents per liter. In view of these changes, the IV infusion fluid was changed to half-normal saline with 5% dextrose to which 40 milliequivalents per liter of potassium was added. The rate was slowed to 250 milliliters per hour, and the insulin infusion was continued at 6 units per hour. 4 hours later, that is 10 hours after admission, the blood glucose was 205 mg per deciliter and the serum potassium was 3.5 milliequivalents per liter. The IV fluids were changed to 5% dextrose with 40 milliequivalents per liter of potassium chloride, administered at a rate of 250 milliliters per hour, and the regular insulin infusion was decreased from 6 to 3 units per hour. JLM continued to improve during the next 12 hours, and she began taking full oral liquids by the second hospital day. At that time, her IV infusion rate was decreased to 200 ml per hour, but her insulin infusion was continued. Approximately 24 hours after admission, JLM's blood glucose concentration was 175 mg per deciliter, potassium was 4.6 milliequivalents per liter, sodium was 144 milliequivalents per liter, and the anion gap had closed down to 16 milliequivalents per liter. There were no ketones in the plasma. The urine contained 1% glucose and moderate amounts of ketones. IV fluids were discontinued, and a rapid-acting insulin was administered subcutaneously 1 hour before the insulin infusion was discontinued. JLM continued to receive rapid-acting insulin subcutaneously every 4 hours according to a sliding scale. 36 hours after admission, JLM was given her usual dose of insulin glargine and insulin lispro and was sent home for follow-up in the clinic. The next question reads, SLH is a 45-year-old, overweight, Mexican-American woman with central obesity, with a height of 5 feet 5 inches, a weight of 165 pounds and a BMI of 27.5 kilograms per meter squared. 3 months ago, she was referred to the diabetes clinic when her gynecologist, who had been treating her for recurrent monilial infections, noted glucosauria on routine urinalysis. Subsequently, on 2 separate occasions, she was found to have a fasting plasma glucose of 150 and 167 mg per deciliter. An A1C was also checked and it was 8.2%. SLH denies any symptoms of polyphagia or polyuria, although lately she has been more thirsty than usual. She does complain of lethargy and takes afternoon naps when she can. SLH's other medical problems include hypertension, which is well controlled on lisinopril 20 mg per day, and recurrent monilial infections, which are treated with fluconazole. She has given birth to 4 children, birth weights, 7, 8.5, 10, and 11 pounds respectively, and was told during her last pregnancy that she had borderline diabetes. She currently works as a loan officer in a local bank and spends her weekends catching up on her sleep and reading. SLH has been smoking 1 pack of cigarettes per day for 20 years and drinks an occasional glass of wine. She drinks at least 2 regular sodas daily and has a large glass of orange juice every morning. Her physical activity consists of routine walking during the day, e.g., to her car. Her family history is significant for a sister, aunt, and grandmother with type 2 diabetes mellitus. All have weight problems. SLH's mother is alive and well at age 77, her father died of a heart attack at age 47. On presentation, fasting laboratory assessment reveals glucose of 147 mg per deciliter, triglycerides of 400 mg per deciliter, and an A1C of 8.3%. The normal range is 4% to 6%. All other values, including the complete blood count, electrolytes, LFTs, and renal function tests, are within normal limits. SLH is given the diagnosis of type 2 diabetes mellitus. What features in SLH's history and physical examination are consistent with this diagnosis? The features of SLH's history that are consistent with type 2 diabetes mellitus include an fasting plasma glucose concentration of 126 mg per deciliter or higher on more than 1 occasion, A1C of 6.5% or more, high BMI with central obesity, age older than 40, physical inactivity, family history of diabetes, and Mexican-American descent. SLH also has delivered large babies, which suggests that she may have had undiagnosed gestational diabetes, a condition that places women at high risk for subsequently developing type 2 diabetes mellitus. Diagnosis on routine examination and mild signs and symptoms of hyperglycemia, such as including increased thirst and lethargy, recurrent monilial infections, hypertriglyceridemia, and indications of cardiovascular disease, that is hypertension, also are typical in patients with type 2 diabetes mellitus. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 330.